Thank you all for joining our session this afternoon. Appreciate you all being here today. If you don't know me, I'm Julia Jenkins. I'm Executive Director of the EveryLife Foundation. I'm going to talk about our newborn screening legislation initiatives, but I'm also going to give you a play-by-play of the different state legislative issues that affect rare disease patients. So there are a number of policy issues, and there's probably more than what are on this slide. And I'm going to go through a few of them. We have Sue here is going to talk a little bit about Medicare for rare disease patients and cover a little bit about the Expert Act. And then we're going to talk about how we can make sure that policy legislators at the state level have an opportunity to learn about all of these issues that affect state advocates affect advocates at the state level, and how important having a rare disease state caucus can be to make sure that these issues are heard by legislators. So some of these bills you might have heard of, some of you may not have heard of. So Right to Try, it's a very trendy bill that's basically been passed in every state. Specialty tier co-pays. Basically requires patients to pay a percentage of the drug costs. Not great for patients. Step therapy requires patients to fail first on a more inexpensive therapy. Also not great for patients. Medical foods. This is a lot of patients don't have access to actual therapies and they need to use medical foods. Those foods are often not covered by insurers. State Advisory Council, there's a few that have been passed in states. So this is kind of a new way that patient advocates are ensuring that patients have a voice at the state legislature. I'll talk about our newborn screening, and I talked a bit about the Expert Act. So Right to Try, is anyone here familiar with Right to Try? Okay. I think this is, we fully support early access to experimental drugs, but unfortunately, with Right to Try, I feel like it's a really good intention, but it's a false hope and a flawed policy. You can see all of the states in green have adopted Right to Try laws, but to our knowledge, not one patient has actually gotten access to experimental therapies through this legislation. Specialty tier out of pocket. Some insurers require as much as 40% co-insurance. So there are some states that have passed some good laws. 9 states have good comprehensive policy: California, Colorado, Delaware. I'm thinking that's Louisiana, Maine. Now I'm like, really, anyway, you see the slide. But we've got a lot of work to do in a lot of other states to make sure that our rare disease patients aren't having to pay co-insurance. Step therapy, which is fail first. There's some good laws. You'll see some of those same states. California has great kind of policy throughout. And you can ask me questions on all of these. I'm trying to go, we're running behind, so I'm not going to go through all of these. These slides will be online. If you have specific questions about these pieces of legislation, happy to answer them. Medical foods, you can see it's all over the map. Lots of states do different things on covering medical foods. State advisory councils, we have them now in Connecticut, Illinois, North Carolina, Rhode Island. And in 2017, if any of you guys are here from these states, Georgia, Kansas, Massachusetts, and Michigan are also looking to pass legislation to build these councils. So now I'm going to talk. Are there any other questions? Are there questions about the other legislation that I just went through very, very quickly before I move on to newborn screening? Yes. Step therapy. So basically, that requires if a new, better drug comes out on the market, an insurance company may deny access to that drug. They want you to take a cheaper therapy and prove that it doesn't work. So you fail first on the cheaper therapy before you get access to the better therapy. It is a terrible, terrible policy. But the only way to prevent those terrible policies from happening is to build advocacy at the state level. That's a great question. Any other great questions like that? No? All right. So newborn screening. How many people in the room have genetic diseases? All right, most of you. How many of them affect pediatric populations? All right, most of you again. So newborn screening right now is often done for many diseases by siblings. So one sibling gets the disease, is affected, doesn't get to treatment, is delayed, and then the next sibling comes along and they start treatment early. And so you can see the difference between early and late diagnosis. And that's basically our newborn screening policy in the country, which is terrible. We really believe that we can do better. Universal screening can kind of be a dirty word sometimes, but I think it is best for our rare disease patients that we are screening for as many diseases as we can screen for. And the fun part about what we do is that we do have this great federal committee that makes recommendations, and then the states do whatever they want. So we have this federal committee. It's called the RUSP. It's called the Recommended Uniform Screening Panel, is what they create. The committee reports to the Secretary of Health and Human Services, which you guys learned earlier is now taken over by a new secretary. What we have found, the RUSP recommends for about 30 or so diseases. Once a RUSP recommendation is made, the states can take up to 8 years to begin screening for the disease that's recommended at the federal level. Most states have to pass new legislation to implement. Parents and advocates like yourself have to go to the state legislature and testify disease by disease, state by state. As you could probably imagine, these legislative delays result in delays in diagnosis, irreversible mental and physical and health challenges, and even death. We believe at the foundation, and I think you probably all share this philosophy that babies should not live or die based on their zip codes. So when we go to policymakers, we say newborn screening saves lives and money, because policymakers like to save money. This staggering fact, many of you probably are aware of it, 30% of children with rare diseases won't live to see their 5th birthday. On average, it takes about 7 years for a rare disease patient to receive a diagnostic. Anyone above 7 years in the room? All right, yeah, a few of you. So it's definitely, we can do better. And newborn screening won't solve it all, but it could help future generations. We are basically collecting data, and if you guys have any data for the diseases that are recommended, when you go to the state legislature, you actually have to prove that it saves money. So for ALD, it can actually exceed $3 million per child in end-of-life care, where the treatment for that disease is actually much smaller, and also the test for the screen is quite cheap. So why would you spend $3 million trying to care for a dying child when you could just save the child at a much cheaper cost? So California actually has a great study. I've never seen the study done in any other states. We're definitely going to be looking at having other states do this study. But California actually found for every dollar spent on newborn screening, they saved over $9. So it really saves lives, saves money, smart public health policy. So in California last year, we were located in California. If you don't all know and saw our boxes, we actually shipped everything here, or we took it on a plane. So we're based in California, and in California they had passed a bill to add newborn screening in California, or add ALD when it was recommended by the federal level. So California was really ripe for new legislation. They had set a precedent saying, we will screen for diseases on the RUSP. So we went to them and we said, okay, we want you to screen for these other diseases on the RUSP. And they said, we're not screening for any diseases unless we're legislatively mandated to do so. And so we said, okay, we will legislatively mandate you to do so. We introduced a bill by Dr. Richard Pan. He's a pediatrician, very well respected in Sacramento. It required, when we first sought the legislation, we went out and we said, we want you to screen for diseases immediately after they are put on the RUSP. We knew we were never going to get immediate, but we put immediate so that we could have some bargaining power when we introduced the legislation. They came back to us and they said, we don't want a time limit. Then they said, okay, well, we'll take 5 to 8 years. We're like, no. So we met in the middle of the 5 to 8 years at 2 years. So it basically allows the state to get the funding to screen and hire the staff, hire the equipment, and start screening babies. So smart policy. The bill was supported by 120 patient organizations, probably some of you in the room, so thank you for that. It passed unanimously through the Assembly and the Senate. It requires the screening of MPS 1 and Pompeii by September 2018, so we got a little win there. It's a little shorter than 2 years. And it was signed by Governor Brown in September, so just 7 months after introduction. It wasn't that easy. We had a lot of pushback on the cost and feasibility of the screening. Again, I talked about the hiring of new staff, purchasing the equipment, purchasing the reagents. There's a lot of concerns about the cost of the actual treatments. For some diseases, it is cheaper to let the child die. That is not an argument that's ever going to sell me to do anything, right? That is an unacceptable answer. And so we are really looking at, what are the unnecessary surgeries? What are the unnecessary misdiagnostics? We had a little girl misdiagnosed with Noonan, she had MPS 1, misdiagnosed with Noonan syndrome, treated with chemotherapy for a disease she did not have. So those types of stories, if you have those in your community, we're looking for those that we can tell them. We also had concerns, opposition from the Hospital Association, opposition from the Department of Health. So we had even though we were able to pass unanimously through both chambers, the reason why we were able to do that was because of the support of patients. It was not, we were able to unite the community behind this legislation and move it because of the patient advocacy support. So that's a little bit about what we did, and now we're bringing our legislation to Florida. So Florida has the first highest birth rate. We're trying to pick the states with the highest birth rates, if you've figured that out. But fun times with state legislature, our California bill would actually be unconstitutional in Florida. Because in Florida, you can't actually refer to the federal government to legislatively mandate what the state will do. So we've got a tailored approach. Lots of states are this way. It's fine. We will take tailored approaches. So we are empowering the Genetics and Newborn Screening Advisory Council at the state level. A lot of states have these councils. We're requiring them to review what the RUSP recommends within 1 year, and then once the advisory council recommends, the state would then have a year to implement. So basically on that 2-year timeline that California is on. So the bill was actually introduced. Bills, got to run 2 this time. Florida requires you to have a bill in both chambers. So the legislation is bipartisan and bicameral. We have 2 great parents in D.C. who have introduced the legislation. Senator Book actually just had 2 twins, well, one, I guess a set of twins, last week, right before she dropped our bill. So Florida is also very unique. We have about 3 months to pass this legislation. Session begins next week. We have to get both bills out of committees by April 25th, and we must get the legislation signed by May 5th. And then we have 15 days to convince the governor to sign. So if you wonder what we're doing after this, that's what we're working on. So how you can help. We are looking for patient stories to illustrate why newborn screening saves lives and saves money. We'd love if you have contacts in Florida, share our action alerts to ask them to write letters to their state legislators. If you have a patient organization that you are a part of, any patient organization is welcome to sign on to our letter of support. If you are in Florida or know people in Florida and are interested in testifying on behalf of the legislation, we'd be happy to have you join us. We do have travel stipends available. Florida's an awkward state. Takes a long time to get from one side to the other, so happy to provide stipends to help people testify. We're also looking for economic data. It's a big problem about proving why newborn screening. We all know why newborn screening is important, but we have to convince the legislators that they want economic data. And if you really, really are passionate about newborn screening and want to be a leader in our efforts at the foundation, we would ask you to join our Community Congress Working Group. That's for actual representatives of patient organizations who help drive our initiative in this issue.